Hello everyone, Dr. Alex Vasquez here with video number 2, kind of reintroducing the antiviral strategy for this year, 2019. Today's conversation is going to focus on the amino acid L-cysteine, and the structure of this presentation kind of includes the following background. I looked at about 250 articles, 60 of which were specific to antiviral or immune nutrition, and I worked on this for about a month, and at this point I have to say that it's at least good enough to present, even though it doesn't say everything that I want it to say. It's good enough, and time to move on to the next topic. So I'm going to move through this at a pretty quick pace, as you might be able to tell. More information will be available on my website, inflammationmastery.com/antiviral. So the first question is for you, the listener, or if you're reading the transcript, you would be the reader. What do you know about cysteine, acetylcysteine, or NAC? I suspect that most medical doctors do not know the following information, or at least most of it. So what are the dietary sources of L-cysteine and acetylcysteine? Biochemical synergists, these would be primary, secondary, and tertiary. Clinical synergists, of course, that would depend on the clinical condition that we're trying to treat. But in this case, like I've already said, we're going to focus on viral infections. So what 4 other treatments could you use with acetylcysteine to help it work better? We could also name at least 4 other clinical uses of acetylcysteine, along with, of course, its contraindications and adverse effects specific to oral administration and intravenous administration. At that point, we should be able to then discuss risk-benefit ratios and cost effectiveness. Let's look at some of those questions in a different way here. Basic information about L-cysteine is that it is, of course, an amino acid. It's a component of glutathione. It's mucolytic and is also FDA approved, not only for its mucolytic effect, but also as a remedy for acetaminophen or paracetamol overdose. I would consider that really basic. I suspect that most, even medical doctors, would know that. Some more advanced information. It's a conditionally essential amino acid, meaning the body can make cysteine from other precursors, including other amino acids, but it's conditionally essential, which means that in some cases we need to provide the amino acid, and if that's true, then we would also need to know at what level or what dosage we would need to provide it in certain situations. It's considered the rate-limiting amino acid for glutathione synthesis, but you'll also know if you read the research that all of the amino acids that constitute glutathione are considered rate-limiting. So one would then need to understand how those amino acids interact one with the other. As I said before, it's mucolytic, mostly via the inhalational route, but we do see significant benefit with oral supplementation as well. As I mentioned before, it's a remedy for liver toxicity due to acetaminophen or paracetamol overdose. Usually that's in the setting of a suicide attempt, and I've given you some dosages here. Intravenous is equivalent to oral therapy if started within 8 hours of the poisoning. After 8 hours, intravenous administration provides greater benefit. It's catabolized in the liver in response to interleukin-6 mediated inflammation. So anytime we see a patient in an inflammatory state, we can be pretty sure that if their CRP is elevated, we know that's a reflection of interleukin-6 mediated inflammation, and we could therefore reasonably hypothesize that they are catabolizing their cysteine in the liver, usually for the sparing of glutamine, and I'll discuss that more later. By this stage of the game, all healthcare providers should be aware of the neuropsychiatric benefits of acetylcysteine and how it modulates glutaminergic neurotransmission. I'm your host, Dr. Alex Vasquez. You can see my information here, and on the following page you can see my notices and disclosures. When I talk about dosages in this presentation, I'm only talking about adult dosages. A lot of the information that we're going to discuss right now is contextualized within my largest textbook, which is Inflammation Mastery 4th edition. You can find out more about this book at various websites, including inflammationmastery.com and ichnfm.org. Inflammation Mastery is still my major book, even though I've derived some other books from it, such as Brain Inflammation, Pain Revolution in Chronic Pain, Migraine, and Fibromyalgia. Also, Human Microbiome and Dysbiosis in Clinical Disease was extracted from Chapter 4, as was Antiviral Nutrition and the paper version of that same book, which is Antiviral Strategies and Immune Nutrition. Inflammation Mastery is really 25 books in one book, and I'll show you how that works out mathematically in just a moment. It's available as a paper book, which usually provides the deepest level of comprehension, but it's also available as a more easily portable and searchable digital book, as you can see here, which enables people to use the digital search feature word for word. Some of my other articles and presentation transcripts are available at my academia page, as you can see here, also on ResearchGate. Video archives have been updated recently and expanded to include 2 new channels on BitChute and Brighteon. As I mentioned before, Inflammation Mastery is really 25 books in one. A typical book has about 60,000 words. Inflammation Mastery has 1.5 million words, which means it's equal to 25 books. So if someone paid $200 for Inflammation Mastery, that would be $8 per section. Again, 25 books, all bound in one book, at again 1.5 million words. For healthcare professionals, this is of course a tax-deductible business expense, and of course increased clinical talent pays for itself. Please take a look at the earlier 2019 reintroduction to the antiviral strategy. That's available on my website, inflammationmastery.com/antiviral. I've provided some other blogs and journal articles here that you can access if you want some more of the background information. My major thesis presented in this work is that only by understanding viral infections can we prevent and treat them rationally and effectively. If we treat without understanding, then we're just fooling ourselves, and we're mostly throwing drugs at a mystery. So before we get started, let's begin with 2 questions. This is number 1. So how would you describe a viral infection from start to finish? I assume that most medical physicians could not answer this question competently. So let's begin by looking at some basic questions. If we're going to talk about viral infections, let's at least know what we're talking about and have a conceptual model that we can work with. So discuss the process of viral infection from start to finish. So I'll answer that question for you in just a moment after we look at the second question, which is described here. So look at this diagram from a relatively recent journal article. This is a diagram that you would find represented in basically any medical pharmacology or pathology book that discusses viral infections. So if you look at this diagram, an astute reader would be able to identify what's wrong with this diagram if this diagram is to be used as our model for viral infections, and I'll show you my answers to that in just a moment. As I stated in the earlier introduction, the first video in this series for 2019, I studied microbiology and immunology and pathology in Chiropractic College, Naturopathic Medical School, and also Osteopathic Medical School. And of those 3, naturopathic medicine certainly provided me the best experience and overall education in clinical microbiology and immunology. What we learned in medical school about viruses and viral infections was very little of practical relevance other than to help us make good scores on standardized tests. What we find when we look at medical education is that somehow vaccines are almost never mentioned during the entire course of medical school education and residency. Now what's becoming popular in this conversation is what's being called vaccine safety education, which is really nothing more than a sales pitch on how to sell and coerce patients into receiving more vaccines. And if you look at this article from 2015, it states exactly what I just said. In many medical school curricula, the subject of vaccines has been entirely omitted or is regarded as a minor subtopic. Most medical school curricula do not offer obligatory courses and/or hands-on training in vaccinology in vaccination. Even during postgraduate training programs in pediatrics, the subspecialty that relies most on the sales of vaccines, vaccinations are rarely a topic. So what we see throughout medical training, including medical school and residency, is that doctors, medical physicians, are untrained in vaccines, and yet they're supposed to go on to receive those vaccines and also push them on their patients. So summary point number 1 here is that medical students and residents are not being educated about the true nature or even basic pharmacology of vaccines. The new vaccine safety training programs center around closing the sale of vaccine pushing rather than legitimate medical and scientific education. In a legitimate educational experience, physicians would be taught to be competent to the goal of optimally helping patients rather than corralling them into the single option that is both self-serving and highly profitable for the medical profession. I'll invite you to pause and reread each of those as I continue to make progress. So We've established now, or I've established, perhaps superficially, but sufficiently, that doctors are untrained in the same vaccines that they then go on to sell. They're also untrained on the topic of nutrition, and that's been well documented now for at least 25 years. And every year, new articles come out documenting this again and kind of bemoaning the situation and saying that doctors need to be trained in nutrition if we're going to advise our patients on nutrition. And you'll notice that that never changes. Medical education is not going to change to include levels of basic clinical and interventional nutrition. And the reasons for that, of course, are political and financial. So on the day of graduation, medical physicians are ignorant about vaccines and ignorant about nutrition. Yet the entire medical profession then goes on to endorse vaccines and continue to spread hatred and ignorance about nutrition. And I'll show you two recent examples of that. So why would this happen? I've given you a list here of 15 different reasons why it happens. I've highlighted a few of these: forced conformity, progressive reward system for pharmaceutical supplication, financial reimbursement and profiteering, nonstop advertising in medical journals and newspapers and everyday magazines and everyday television shows, including embedding pharmaceutical information within the storyline of certain television dramas and movies, etc. And of course, we all know now that the drug companies bribe politicians so that they'll write laws mandating that the citizens have to receive these drugs in the form of vaccinations. So when you combine that with the corruption in medical journals, including the news, moving on to politics, and then the financial gain that all that results in, which then leads to more contamination of the research and politics, I call this the pharma echo chamber, socio-political matrix, and power vortex. And as you can see here in the diagram, this is, of course, a vicious cycle. And that's fed by the misinformation machines such as Medscape, as you can see here, Medscape Family Medicine 2019. Vitamins and supplements, they say, are a waste of money. Obviously, that's not the case, and I'm going to show you that in today's presentation. You can also look at this article from JAMA, kind of representing the same idea, and that is that you shouldn't use nutritional supplements. They called this a nail in the coffin for fish oil supplements after they very selectively reviewed some notably horrible research. So what they did here is a tremendous disservice to the American and international public by misleading them into thinking that fish oil supplements are inefficacious, when in fact any quality data shows them to be quite efficacious for various different conditions. So we have to appreciate the paradox, and that is that medical doctors are untrained in nutrition, and yet food is killing the majority of people in so-called industrialized or advanced nations, as well, of course, in the poor and exploited nations. This article from the New York Times, published in 2019, states, "Our food is killing too many of us. Improving American nutrition would make the biggest impact on our healthcare." So any reasonable person should wonder why medical education consistently excludes the topic of nutrition. And as I state at the bottom of this page, for every conversation that is prohibited, powerful financial and political groups are funding and enforcing that censorship. If we talked about healthy diet, that might upset the processed food industry. If we talked about lifestyle, then eventually we would have to talk about creating a social structure that supports a healthy lifestyle. If we talk about chemical exposures, that might upset the chemical and petroleum industries. We used to talk about physician burnout, now it's called moral injury, and at some point it's going to be called physician abuse and exploitation. And of course, we still don't talk too much about solutions to gun violence. What we do talk about is anything that fits the pharmacocentric medical paradigm, and that is that healthcare centers around drugs and surgery. Drugs are the assumed or presumptive solution to all healthcare problems, regardless of the dangers, costs, inefficacy, or the existence of better options not taught in medical school and residency. If any better solution is not a drug, then it is not considered a, quote, realistic, unquote, solution. And by the way, somewhat as an aside, vaccines do not replicate the immune response to natural viral infections. Most major natural real-world viral infections are immunostimulatory and immunosuppressive at the same time, resulting in a somewhat balanced and modulated inflammatory response. For example, interleukin-10 is one of the most pivotal cytokines manipulated by viruses. If you'd like to read more about this, you're welcome to pause the video at this point, and you can also read the following page, which continues that discussion Meanwhile, I'm going to move on in the direction of talking about acetylcysteine, which is our topic of the day. So my first question was, discuss and describe each of the main components of a viral infection, and I've discussed that here. Step number one, you have to acquire the virus. So you have to be exposed to the virus, but mere exposure is not sufficient to create a viral infection. Contrary to the fear-mongering that you're exposed to every day on television and in the news, exposure does not equal infection. Other things have to happen. Number one, the virus has to penetrate into a vulnerable cell, and you have some control over whether or not that penetration occurs. That is a nutrition-responsive process. Step number two in a viral infection is the replication of that virus. Viruses replicate via human cellular machinery, so to speak, and I'll show you some examples of that in just a moment. Step number three of any active clinical viral infection is the immune response, and step number four are the cellular and systemic consequences. So when I talk about viral infections, I say that those are the four main components of a clinical viral infection. I'm not looking at this from the perspective of microbiology nor basic pathology either. Clinically, this is what we see as the major components of a viral infection: acquisition, replication, immune response, and the systemic and cellular consequences. Recuperation from that viral infection usually takes place on its own if steps 1 through 4 are addressed therapeutically. So how would we address each of those components from a preventive or interventional standpoint? Well, we can address the acquisition and penetration of that virus by improving barrier defense and, of course, including sanitation, whether that's plumbing or hand washing. We can also neutralize those virus particles through the use of certain nutrients and botanical medicines, such as licorice, for example, also zinc ions, which are applicable in some clinical situations. Replication of the virus can also be inhibited by the use of nutritional supplementation, and of course the immune response is very dependent on adequate and hopefully optimal nutrition. To address the cellular and systemic consequences, we can also promote protection and recuperation via nutritional supplementation, and addressing steps 1 through 4 helps to resolve this viral infection as quickly as possible and as completely as possible for each individual patient. The problem with the way that medical physicians are trained is that they're often trained to think of viral infections from a microbiologic standpoint or from a pathologic standpoint and not from a clinical standpoint. If you look at a diagram like this, which I just showed you a moment ago, you could find a diagram like this in any microbiology or pathology or pharmacology textbook. Why is that the case? It's because this model of viral infections services the pharmaceutical paradigm, because this introduces the way that antiviral drugs work. So you'll notice that the way medical education works is that basically from day one, and then again in microbiology class, and then again in pathology class, and then again in pharmacology class, the model of disease is tailored to the drugs rather than the drugs and the interventions being tailored to the actual clinical disease that we're trying to address. So let me state that one more time. In medical school, the disease models that are taught are those that service the drug paradigm. Rather than having our paradigm center around patients and real clinical entities, what we learn in medical microbiology and medical pathology and medical pharmacology is we learn to appreciate diseases to the extent that we can service those diseases with pharmaceutical drugs. Well, what if a great intervention exists that lies outside of that pharmaceutical model or that pharmacocentric model? In medical school, you're probably not going to hear about it if it's not a drug that some company is trying to sell. So we have to step out of the medical and pharmaceutical model if we're going to appreciate viral infections in a way that helps us intervene clinically with a greater degree of safety and effectiveness. What we have to do is escape the simple models that service the drug paradigm by limiting the scope of considerations exclusively to those which are targeted by prescription drugs. And before we move on, I'll state that one more time. What we have to do is escape these simplistic models that service the drug paradigm by limiting the scope of considerations exclusively to those that are targeted by prescription drugs. We have to escape that pharmacocentric paradigm. So given that antiviral nutrition is virtually excluded from the conversation on antiviral strategies, what I've done over the last couple of years is try to create a new model that incorporates antiviral nutrition and immune nutrition into our therapeutic conceptualization of how we can address and prevent and treat these viral infections. In fact, some of you might remember back in 2014, I published an article on greenmedinfo.com. The proof is in the panic. We need a new strategy against viral infections. And one of the things I said in that introduction is the fact that we have so much panic around viral infections is evidence that we don't understand these viral infections sufficiently to manage them and treat them and prevent them. So what we need is not simply new treatments within the same model, we need a new model of viral infections if we're going to gain new insights, again, into how to prevent and treat those. So when I wrote this back in 2014, I'm sure many of you remember, that was the year of Ebola and all the fear and unnecessary panic around that. And what I stated then is the fact that these viral infection health crises exist in these modern times is primary evidence of the failure of our current systems, both in healthcare and education, and the need not for new treatments within the same model, but for a new model better suited for international distribution, disease prevention, and broad spectrum effectiveness. And you're going to see that represented in today's presentation. Again, only by understanding viral infections can we prevent and treat them rationally and effectively. So let's dive into today's information. Again, anytime you want to pause or rewind the video, you are, of course, able and welcomed to do so. I'm going to try to make quick progress through this presentation so it doesn't take an excess of time. Structure of today's presentation and some of the upcoming videos: orientation, definitions, clinical use, placement within the four-part strategy, also human patient evidence, estimations of risk, cost, benefits, and collateral benefits, also a summary at the conclusion. But again, we have to place things within a workable model, and the model that I've presented is focusing in on the virus, that is acquisition and penetration, also mutation. We can control that to some extent with nutritional supplementation, replication of that virus, the immune response, and the cellular and systemic consequences, which we can help strengthen through nutritional supplementation. So each aspect of a viral infection can be influenced favorably with the use of nutritional supplementation. And that's the benefit of this model, my model of viral infections. It allows for antiviral drugs. It does not exclude necessarily vaccines, but it does allow a broader range of considerations and therapeutic interventions, which mostly focus around nutrition and botanical medicines, but also some other pharmaceutical drugs, for the safer and more effective management of these viral infections. So based on this model, from start to finish, each of the four main stages or components of a viral infection can be favorably modified with the use of nutritional supplementation. The same cannot be said of vaccine and drug interventions. So this new model provides us a way to deliver better healthcare, better based on criteria of effectiveness, safety, affordability, availability and distribution, generalizability, and collateral benefits. So what you'll notice, for example, and by contrast, what you'll notice is that in the pharmaceutical model, they want to create a different drug for every viral infection. They want to create a different vaccine for every infectious disease. Rather than looking at how to strengthen the human organism and improve immune responses and cellular responses, they want to customize a patentable drug for each and every of hundreds of infectious diseases, and that's just impractical. However, what is practical is strengthening the human organism and using certain pharmacologic and preventive measures that are readily available to help us control these infectious diseases. So having said all of that for the introduction, now let's dive into N-acetyl-L-cysteine, NAC, or acetylcysteine. So as the name suggests, acetylcysteine is simply the amino acid L-cysteine with an extra acetyl group. So the acetyl group itself is actually quite small, as you can see represented here. Acetylcysteine is natural. It is found in some foods, most notably onion and garlic. Acetylcysteine is FDA approved and used in hospitals internationally, mostly for the treatment of acetaminophen or paracetamol poisoning. Generally speaking, it's more than 97% effective if administered within 8 hours of the poisoning. Acetylcysteine is a direct antioxidant, but most of its benefit comes when it's incorporated into the tripeptide glutathione. Glutathione is an antioxidant, but it's also a conjugating agent, and that is the body conjugates glutathione or attaches glutathione onto toxic molecules to make them less toxic and more easily excretable. So, for example, after a person's been poisoned with acetaminophen or paracetamol, acetylcysteine, which then becomes part of glutathione, is used to control some of the free radical damage, but also used to bind onto the acetaminophen molecule to make it less toxic and more easily excreted so that it's carried out of the body, where of course then it can't continue to cause damage. So that's what's meant when we talk about using acetylcysteine to produce more glutathione. Glutathione is commonly referred to as the quote-unquote master antioxidant, and it's also a conjugating agent which helps to detoxify or remove the toxic property of, and also conjugate and therefore help excrete certain poisonous substances, whether it's acetaminophen or another toxic molecule. Within the first 8 hours of poisoning, oral administration is equal in effectiveness to intravenous administration. After that time period of about 8 to 10 hours, then intravenous treatment becomes more effective. Obviously, not all patients can handle oral administration, especially if they're already in liver failure, or if they have excessive vomiting, or if they have altered mental status, which increases their risk for aspiration and choking. Also, once patients enter into shock, their low blood pressure reduces gut perfusion and therefore reduces absorption of the NAC. So in all of those situations, the intravenous route is preferred. So now we're going to start introducing the idea of dosing. The typical loading dose for orally administered NAC after poisoning is 140 milligrams per kilogram, and that comes out to about 11 grams for an oral loading dose. But again, this is not for everyday use. This is for the clinical setting of acute poisoning and impending liver failure. At that point, 11 grams of NAC can be life-saving. The second major hospital use of acetylcysteine is for its mucolytic effect, and that is acetylcysteine helps to dissolve mucus so that patients can cough up that mucus and keep their airways open. And what's also been shown is that acetylcysteine in the treatment of lung diseases also improves antiviral and antibacterial immune function. So why would we use NAC or acetylcysteine instead of just using the natural form of the amino acid L-cysteine? And the reason for this is that NAC is less toxic, it's more stable, and more soluble in water. On the next page, you can see a document that I downloaded from the FDA website discussing the administration of oral NAC in the treatment of acetaminophen overdose. You're welcome to pause the video and take a read of that document. You can, of course, also download the entire document. Meanwhile, I'm going to move on in this presentation. On the following page, I discuss some of the consequences of overdosing, whether it's by intravenous route or oral route. However, despite the fact that we of course have to be cautious and reasonable in our administration of NAC, NAC is remarkably safe, and the vast majority of the studies that I've reviewed in preparation for this presentation have shown minimal and often zero adverse effects, even from very large doses. So yes, adverse effects can occur, they have been documented, but they're very rare and typically not seen, especially with oral administration. Let's take a look at some of the benefits provided by acetylcysteine administration. So not only is NAC safe, affordable, and widely available, but it also functions through several different mechanisms that I'll discuss on this page. Starting with number one, it is an antioxidant. It is a precursor to the so-called master antioxidant glutathione, and it's also hepatoprotective. Again, glutathione is an antioxidant, so it kind of blocks or scavenges free radicals, but it also is a conjugating agent, which means, especially in the liver, toxic agents and drugs are conjugated or bound to glutathione, which is then excreted either through the bile or through the urine, depending on the size of the total conjugated molecule, which includes the glutathione moiety and also the toxic chemical to which it was bound. Number two, as I just mentioned, NAC is largely used for its ability to increase endogenous production of glutathione, which is used as a phase 2 conjugating agent. It's also mucolytic. It helps to dissolve or thin mucus. It also helps to dissolve biofilms, which are the protective kind of protein barriers around colonies of different microbes, especially bacteria. It's also anti-inflammatory, and it's anti-inflammatory via several different major pathways, including NF-kappa B, NLRP3 inflammasome, and also the mTOR pathway. I'll talk about NF-kappa B more in just a moment. NAC can also be described as immunopotentiating, And that is NAC helps to enhance immune defenses against intracellular pathogens, and that includes, of course, some bacteria, such as tuberculosis, and by definition, that includes all viruses. Number 7 on my list, NAC is directly antiviral. It's also indirectly antiviral through several different mechanisms. NAC has been shown to be effective against influenza virus, HIV virus, and dengue virus, among others. Number 8, NAC is antipyretic. It helps to lower fever. It also is anticatabolic or anticahexic, and that is it prevents muscle wasting, at least in part, by sparing glutamine. So in some end-stage diseases, so for example, in end-stage cancer, in end-stage HIV and AIDS, what we see is a catabolic process or a cahexic process where people undergo rapid muscle wasting and also wasting of the immune system and internal organs. So that's called cachexia, and NAC can be used to countermeasure those catabolic and cahexic processes. Number 10 on my list, NAC helps protect mitochondria. It also helps protect kidneys. It also helps to protect the brain, so it's neuroprotective and neuromodulating by affecting glutamanergic neurotransmission, and I'll discuss that more toward the end of today's presentation. It also helps to lower a group of tryptophan metabolites called kynurenines. It also helps to enhance dopamine while lowering, as I just mentioned, glutamanergic neurotransmission. It also helps to lower homocysteine by direct binding. Newer research in animals and in humans has shown that cysteine helps to suppress appetite and helps support fat loss while maintaining muscle mass. Number 17, NAC has been used in the clinical chelation of arsenic and also methylmercury in acute and chronic poisoning. And finally, number 18 on my list, of course I could have gone on, but I decided to limit it to what I could fit on one page. NAC has also been used in the treatment of refractory thrombotic thrombocytopenic purpura and also dengue virus hemorrhagic fever. So among that list of 18 benefits of acetylcysteine, I'm going to focus on the 4 that are mostly relevant for the treatment of viral infections. As I just mentioned, I could have gone on, but I am trying to limit this for the sake of practicality. Antiviral mechanisms of NAC and cysteine include the fact that it spares glutamine. It also supports antioxidant and glutathione defenses. It helps to reduce viral mutation. It's also mucolytic and expectorant. NAC also supports the antiviral mechanism and function of mitochondria, and specifically, it helps to block the NF-kappa B pathway. Let's focus in a little bit on that NF-kappa B pathway because it's certainly worthy of discussion and understanding. Actually, I remember reading about this back in 1994 when I used to subscribe to Nutrition Reviews, and at that time they had published a review article discussing the antiviral benefits of NAC and how NAC was actually superior to glutathione in inhibiting HIV replication. So again, I very clearly remember that in 1994, and these were probably the articles that were reviewed at that time. This particular article showed that NAC was more potent than glutathione in its antiviral activities, and another article showed the same, namely that NAC was able to block viral replication. A truly masterpiece article on this topic was written in January of 2001, as you can see here, from Journal of Clinical Investigation, Hostile Takeovers, Viral Appropriation or Misappropriation of the NF-kappa B pathway. This article was written 18 years ago, and here in 2019, this article remains an absolute masterpiece on this topic. So I'll read to you 2 sentences from this article just to kind of emphasize and bring home the point that I'm trying to make here, and that is that NF-kappa B is a pathway within human cells that viruses basically hijack in order to promote their own replication. So if we can control that NF-kappa B pathway, we can then modulate or at least partially control viral replication, and indeed we can do that through nutritional supplementation. So as you can see here through my multiple highlights, viruses have evolved to modulate the NF-kappa B pathway to enhance viral replication, host cell survival, and evasion of immune responses. And again here, viral activation of NF-kappa B. NF-kappa B is activated by multiple families of viruses, including HIV, hepatitis B, hepatitis C, Epstein-Barr virus, and influenza virus. So again, this is Journal of Clinical Investigation, 2001. In 2005, I published a review article on this topic discussing the nutritional and botanical inhibition of NF-kappa B which is still considered the major intracellular amplifier of the inflammatory cascade. You can access and download this article for free from my page on academia.edu. Let's look at another article that confirms many of these ideas. This article discusses NF-kappa B as a target for anti-HIV chemotherapy. You can see this was published in 2003, discussing NF-kappa B as a lymphoid-specific transcription factor. Transcription factors are basically molecules that translocate typically from the cytoplasm into the nucleus to promote gene expression of certain gene patterns, and in this case, NF-kappa B activates a pattern of gene expression associated with infection and inflammatory disorders. So again, NF-kappa B is a transcription factor critical to the expression of inflammation-related genes. NF-kappa B, as you can see here, plays a major role in the regulation of HIV gene expression. Upon activation, NF-kappa B is released from the inhibitor kappa B protein, moves into the nucleus, binds to its sites on the HIV long terminal repeat to start transcription of the integrated HIV genome. Combined drug therapy has presented the problem of resistance, and that is resistance by the virus because the virus mutates to evade restriction by antiviral drugs. The authors go on to say, however, targeting NF-kappa B for the suppression of the virus does not present the problem of viral resistance because NF-kappa B is a component of the human biological machinery, so it doesn't have the same ability to mutate, nor would it have that ability in the same way that viruses do. And that's because NF-kappa B is a normal part of the human immune system and is not subject to mutations as is the virus. So every year, for example, you hear about influenza virus mutation. That's why they keep pushing a new flu vaccine every year, because the virus mutates. Well, if we were to change our focus, and instead of focusing in on the virus itself, if we were to focus in on the machinery that replicates that virus, a large part of which is this NF-kappa B pathway, if we focus on what we can control, which is the NF-kappa B pathway, then we wouldn't have to concern ourselves every year with viral mutation. And let's look at one more article now that states the same. So this abstract from this article in 1992 actually summarizes a few things I've already said and also a few things I'm about to say. So I'll take a moment to read you some of the highlights. N-acetylcysteine, or NAC, or acetylcysteine blocks HIV expression in chronic and acute infection models. They observed an antiviral effect of NAC, which they stated is due to the inhibition of viral stimulation of reactive oxygen species, which are produced in response to inflammatory cytokines. And note what they say toward the bottom of this page. NAC is different than many other antiviral drugs in that it inhibits host-mediated stimulation of viral replication. That's that NF-kappa B pathway that I just mentioned, arising in a normal immune response. In addition, NAC inhibits the action of inflammatory cytokines, which may mediate cachexia, or muscle wasting, which I also already mentioned, and it may therefore alleviate the wasting that accompanies late stages of AIDS. So that's exactly what I had already stated. Now let's go on to look at a few more mechanisms before we get into the clinical studies. So again, this particular article alluded to the antiviral effect of NAC being the NF-kappa B pathway and also reducing free radical formation, and you'll see that echoed in this more recent article from 2016. Title of this article from Current Zoology is Oxidative Stress Favors Herpes Virus Infection in Vertebrates. So you'll see here from the excerpt that viral infections create a vicious cycle. Viral infections induce the production of more free radicals, but those same free radicals then support additional viral replication. So you see a vicious cycle. Virus infections cause free radicals promote viral replication. So if you can break that cycle with antioxidant therapy, such as NAC, then you can break the cycle of viral replication. And in this case, they're specifically talking about herpes virus infections. But of course, herpes viruses are a huge family of different viruses, not simply herpes simplex 1 and herpes simplex 2, but also the zoster virus as well as others. So now we're going to start getting into the human clinical research, and in this case I'm going to focus in on human clinical trials and review articles published in clinical medicine journals. So let's start with this one from Advances in Pharmacology. This was actually a textbook, Advances in Pharmacology in 1997. This is a masterpiece article written by several international experts at the time, including the man, the myth, the legend, Wolf Droge, who you can see is listed as the primary author. So let's look at a few excerpts from this very long and painfully detailed article, which was then painfully ignored by the medical community. This article shows us that depletion of cysteine leads to catabolism of glutamine and an increase in glutamate. Now that's very important. So I'm going to read that sentence one more time, and then I want you to think about why that's important, and then I'm going to explain to you the, in my opinion, obvious reasons why this is important. So depletion of cysteine leads to catabolism of glutamine and an increase in serum glutamate. So what does that tell you? Well, it obviously tells you that when cysteine becomes depleted through viral infections, that's going to lead to catabolism or destruction of glutamine. So when you lose one, you also lose the other. And that's very important, because where is glutamine going to be pulled from in order to support normal physiology in the face of depleted cysteine reserves? That glutamine is going to be pulled from muscle, and it's going to be pulled from the gut. That's going to lead to leaky gut, increased bacterial translocation, and increased risk of infection, inflammation, and sepsis. Also, when glutamine is pulled from muscles, that's going to lead to muscle wasting, also what we call cachexia, and that, as I already described, is one of the end stages of terminal AIDS and terminal cancer. So quite obviously, you can measure those things in the blood and determine where a patient is on the spectrum of cysteine sacrifice, which is my terminology for discussing this phenomenon. So based on that information, you can use that clinically to determine where a patient is on the spectrum of cysteine depletion and cysteine sacrifice, leading then to glutamine sacrifice. You can measure blood levels of cysteine, glutamine, and especially glutamate. So if you measure those blood levels, that gives you an idea of where your patient is and perhaps even what dosage you might need to use when implementing NAC acetylcysteine therapy. And that's exactly what they had stated in this article, is that dosages can be customized based on laboratory and other clinical parameters. Let's move on to point number 2. Increased glutamate inhibits cellular uptake of cysteine, thereby exacerbating intracellular glutathione deficiency. So my take on this, as I said before, this is a painfully insightful article on the biochemistry and clinical implications of NAC therapy, especially but not exclusively relevant to HIV infection. It's a long article, and it was brilliant and then ignored, and that's the painful part of this article. So we can all suffer through a long and complex article, but to see such a brilliant article then ignored by the medical profession as a whole is really a tragedy. So again, this is from 1997, 22 years ago, and here's what they stated. They propose that an increase in plasma glutamate is a pathogenic factor in its own right and is responsible for the decrease in intracellular glutathione in HIV patients. This same phenomenon of depletion of cysteine leading to depletion of glutamine, leading to increased serum glutamate, leading to a blockade of cellular cysteine uptake, is also what causes reduced immune function in advanced cancer patients. So you might want to pause the video and let all of that sink in. Meanwhile, I'm going to move on to the next page. Adequate glutathione and cysteine is necessary for immune function. I'm going to say that again. Adequate glutathione and cysteine is necessary for immune function. So I want you to think of cysteine not simply as a structural building block for the tripeptide antioxidant glutathione. I want you to think of cysteine as being basically a fuel for the immune system. Now, we're all used to thinking of glutamine as a fuel for